welcome to all of you to today's session. So first of all, we are going to introduction, and this is the name of our institute. Today, in this session, what we will this is a moral alert, and we will try to give you some guidance for your future AKT preparation and how to read your question. That means the learning bundles. Also, you will get some idea. And what will be the contents of your learning. This is very important. It is not only some questions, some answer. And if you read something which is not important for the exam, but important for your knowledge as a professional, it will not be fruitful for you as well. So we have to consider our time planning, and dividation of the time also, that which area we are weak with, we have to give more attention there. But it is not important that I am weak of some topics, I will give more attention. We have to consider the topic I am weak with, how much important this topic for your exam also. Most of you know about this, but I'm just reiterating and repeating the messages to make you more oriented for your preparation planning. So let's go now. Just some basic informations already you know. If you don't know, you just try to know from today that in the AKT exam, in coming time till now, until the regulations we are having, there will be 200 questions and will be of single best answer type, single best answer. We will show you today some examples of single best answers, and you will be given 3 hour 30 minutes time for this. 3 hour 30 minutes. It means that on an average, you will get 1 minute per question. You have to answer one question in 1 minute. This is very important for your time management. Anyway, if you have any further question, you can ask later also in common discussion part. But let me go with my topics first. Try to know that the content of the exam actually will reflect the contextual aspects. Just to remind you that if we are appearing in MRCGP AKT exam in the South Asian perspective, so our context will be South Asian. But it is also true that the contexts are not too much varied. The topics are not too much varied. But variation will happen in our evaluation process, especially the investigation planning a little, and more in the management plan, because management actually will be based on the available resources also. The cultural and the religious belief of patient also. For that, there may be some contextual difference. If you go through your learning bundles, you will come to know detail, but the modification we have to know about, we need to go with a group discussion, or sometime you have to register for some courses like we are providing anywhere, whatever you are saying. It is true for everywhere in the world. And at a glance, if we try to understand the broad heading core, the content of the exam, around 80% question will come from the clinical medicine. Clinical medicine, that means disease, its symptom, signs, investigation, presentation as such. And there are some 10% question on an average will be the evidence-based, that means biostatistics, and some other question including ethical issues, organizational structures and others. It will be of 10%. So you see that if you theoretically, rather to say, if you become ignorant of these 10%, 10%, if you become almost 100% well-oriented with the clinical medicine, so it will be easier for you to pass exam. But some legal issues and other issues, evidence-based medicine will be very simple. The question will be very few. In our previous recall session also, you can remember, you have seen it. And already I have told you the broad topical medicine will be discussed in these headlines. Discuss means the question will base on the disease factors, the symptom signs as well, investigation and management. These are the broad heading for any disease to study with. So I'm requesting all of you, if you don't understand anything, you can raise your hand anytime in the system, in the Zoom, so we can discuss. Just to enlighten more about the subject matter of the questions, the topics which will be common day-to-day problems. Suppose South Asian disease problems, potentially preventable conditions will be very important, and there will be less common disease, but these are very life-threatening. Suppose, for example, the meningitis, bacterial meningitis are not much common, but life-threatening. For that, we have to know it. Multiple sclerosis, for example, will be disabling disease, but not much common in South Asian perspective. For that reason, we have to learn some life-threatening and disabling disease, though it will not be common to us. Okay. And very unlikely we have to encounter, which are very rare, especially the management issues. We don't need to learn, but we need to know almost all diseases about what is the disease, especially the diagnostic issues will remain important for almost all diseases which are happening throughout the world. But the management part of many diseases actually will not be available in the exam, especially those which are very rare disease and where the impact of the disease are not too much high. And the diseases usually be managed in the secondary, tertiary care, not in the primary level. Remember, we are appearing in the exam in the primary level, in the general practice level. It is also important. So these are some philosophical thoughts and understanding for the exam. And these are the reference materials. Don't worry that we have to look at as a reference books. Remember, reference doesn't mean to read A to Z. Just reference means whenever you need, you just look at this. From this list, our humble suggestion, the leading one is Oxford Handbook of General Practitioners or General Practice. Oxford Handbook of General Practice. And now currently 5th edition is ongoing, but anytime the edition will be changed, you will get it easily. In many sources are there. There are, you see, Oxford Textbook of Medicine. If you have anyone have seen the Oxford textbook, it will be a very big book, but it is for learning purpose to improve our understanding. There is another book also for the family medicine. Author is from Australia. It is also a big book of family medicine, but in our observation, we like to say you that no need to go through too much detail, many books, big books. The Oxford Handbook of General Practice will remain as the leader for your understanding, as well as the learning material, some discussions, some important notes. That will be the main your learning materials for your exam ahead. Okay. And suppose in the below, nice and sign guidelines. If you have the experience of reading these, each guideline is a very big thing. All are not important. Very important thing you have to look from the guidelines. Sometimes your learning materials will guide you also that these are the extract of the guidelines. So NICE guideline is very well known. This is UK based guidelines. Some concept will come from the NICE guideline. So this is the appearance, the face of the book, Oxford Handbook of General Practice. Just for your easy memorization. I hope all of you oriented with this book. This book not only for your exam purpose, in our experience, this book will help you for your practice as well when you see the patient. for proper decision making. Is very fruitful and useful book. And the eligibility is always under evaluation by the Royal Colleges. Possibly within very short time in the last, this eligibility is modified. So you will go through by yourself. This is the time not to tell you detail. You will get many where this. If you don't understand anything, you can communicate with us. Okay. So with this few introduction, we are going to our next issues. But anyone, if you have one, if you need to raise your hand to talk, ask anything until we discuss, you can raise. Otherwise, we are jumping to the other topic. Possibly we can jump now as we believe that you understood well. Okay. So now the component in the headlines, the question will be text-based questions. There will be pictorials, clinical pictures, X-ray, ECG, lab data. What about the ultrasonography? Still, this ultrasonography is not included. More likely, there might be some messages in the text-based questions, the informations or findings in the ultrasonography. But under the pictorial, usually ultrasonogram is not attached with the question until now, but anytime, because in the world, there are some other exam systems where the pictures of different investigations are produced. Ultrasonography, one of them. We will try to show you one picture also today. Will be easy for you. Don't worry. So for the future, actually, forecasting, we are thinking for you and trying to give you advanced messages. So let's go on with text-based question now. And I believe that today, how we will introduce you the scenario, it will be the best suitable for your learning. Not only just as presented in the learning material in your PDF, but how to read PDF also, you will get an idea here. I hope it is possible. Suppose this is a question. Now, I am requesting any one of you, please help me to read the question. For example, today we will not discuss too much questions, just we will give one sample from each headline. So who will be helping here now to read this? Dr. Ashraf, please.
Assalamualaikum, sir.
Please, can you read this?
Yes, sir. A 58 years old lady comes to you for a repeat blood pressure reading. She has been seen by two colleagues over the last 3 months who have found readings of 142 over 92 millimeter of mercury and 150 over 88 millimeter of mercury. Today's best blood pressure is 144 over 82 millimeter mercury. She has no family history of hypertension. Her BMI is 24 and she does not smoke. What is the best next step?
Okay. Thank you, Dr. Ashraf. Actually, you understand that your question will not be as such. Suppose this is called lead in. This is the stem. The first part is the stem. This is the lead in. And the next will be the options. You have to choose your correct option. We made it as such because the way will be, after reading this, what will be the best next step? You have to synthesize by yourself. Then we will show you the options. So who can try now? Or if you don't understand the question, anyone can ask us. We will try our best. This is a patient of hypertension diagnosis. Concept is hypertension diagnosis. In the meantime, already you know how to diagnose. You have to get the readings of different settings in different times. Is it diagnosed now? First question. If it is diagnosed, should we start the treatment now? Or should we investigate initially before starting the treatment? These are many things will be there. As a doctor, we have to decide by ourselves. Our patients will not tell us, doctor, I am giving you 5 options for me and choose the best one for me. Actually, it will not happen. This is only for exam purpose we are preparing with. This is the real scenario that patients are coming to us to know about the best step suitable for my patient. So please, anyone try. What will you do for this patient now? Can anybody try? If
So
I
start.
like to make it simpler and easier, in such questions, you have to identify some key points from the informations given. So Dr. Ashraf, can you say some key points here?
So last 3 months, mm, they find blood pressure high.
High. So there are sequential measurement of blood pressure found high up. High up means this is diagnostic of hypertension. Is it?
Yes, sir.
This is key message. Fine. Then
Mm, Then her age also
58.
58,
If we can recall our guidelines, we need to remember the age also. Very good. Then
and now her blood pressure also below high.
above the cutoff value. Systolic is above the cutoff value, right?
Yes,
144. That means we diagnose today the person is hypertensive, though it is a very initial stage, a little high.
yes, sir.
Is there any other informations can guide us for decision making? Is family history of hypertension is important information here?
Yes, sir. Sometimes,
For this
but
patient will be important, and for what? For why?
sir, in this type of patient, patient is already elder in age, and
Now you got the
before,
age, but the family
yes,
history, we know that we are seeing the patient taking the history. Here, family history important. So there is no
yes, sir.
family history. But asking you that is there family history important for hypertension? Where
In
this
here,
patient does not have.
in this question, maybe it's not required.
Yes. No. It is required in a sense. Suppose here is does not smoke. That means smoking history in hypertensive patient important in a sense that the patient will have more cardiometabolic risks. Patient having
Yes,
the
sir.
family history, it is a risk. That means why we are worried for hypertension, because hypertension will cause damage to important organs, including blood vessels. Again, smoking also will damage the blood vessels and important organs. So in the decision making, suppose if you want to give the treatment today, if one patient having smoking history, one patient have strong family history, blood pressure is above the cutoff value of hypertension, this is one patient. Second patient today, like what we are discussing here, just high blood pressure without any background risk factors, other risk factors, even BMI also 24, age is only 58. So the treatment of two group of the patient will be a little different. Further evaluation will be a little different. Clear now, Dr. Ashraf? Dr.
Yes,
Ashraf,
sir.
be connected with me, please. Huh? When we
Yeah.
discuss, it will be easier. So keeping in the mind what usually we do in our chamber. I'm discussing more only for this question. Don't worry. In the subsequent question, I think detailed discussion will not be needed. Just try to remember of first discussion, what we are with now, the basic to analyze, to explore a patient, what we need to think of. So in our chamber, some patient we are giving directly some investigation. Some patient we are giving directly some medication. Some patient we are telling, okay, don't do anything. You measure your blood pressure, record it at home, and come back with the record in different ways. These are the steps. So if we show you some key messages, many key messages will be there according to your understanding. We are trying our best to give you in the red color actually to highlight this thing. This is the record. This is the other cardiometabolic risk factor present or absent. This will be a deciding factor for you. Otherwise, other things also deciding. If you want to give the treatment, the patient's age will guide you as well. So now, Dr. Ashraf, you can say what will be your plan in your chamber.
Sir, should start antihypertensive drug?
Antihypertensive drug, preferably if you think it will be a calcium channel blocker because age is 58.
Yes, sir.
Okay.
Um,
Any confusion?
yes, sir.
Okay, you will give today calcium channel blocker medicine to control the blood pressure. I believe that our colleagues today at us here, they may have some difference of opinion. It is very practical. So who will give a different opinion here, please? What do you like to do? These are very common disease, diabetes and hypertension. Every GP should know almost details. So anyone wants to give anything other than medicine? Even what Dr. Ashraf said, it may not be option as well. No problem. Others are feeling shy to tell. Why you are feeling shy? You are giving the decision in your chamber, doctor. So try to share today. It will be rather useful for you. Any different opinion, not like Dr. Ashraf today. No more. So we have to proceed. Before going, we need to, if we want to evaluate this hypertensive patient, we need to remember this thing. This blood pressure, where actually you see, Dr. Ashraf, can you remember what was the systolic blood pressure? 144.
Yes, sir. Yes, sir.
Is it the clinic blood pressure, right? That means our
Yes, sir.
chamber blood pressure.
Yes, sir.
So if it is a more than 144, just above, next step you see here, ambulatory blood pressure
Ambulatory
monitoring
blood pressure
or home blood pressure monitoring.
monitoring.
Okay. When is to give the treatment, there are some other options in the guidelines. If you don't see it, you cannot give correct answer. Okay, I'm just showing your background knowledge, what you need to know about a topic. This is one of that topic for hypertension. So we are not discussing detailed hypertension. We are discussing the technique today, just enlightening you about a topic today is hypertension. So if this is the situation, maybe this will be the best answer. Now we need to see, is the answer given there or not in the stem? Is there? Dr. Ashraf, as you are volunteer, please have a look. Is the option there?
Yes, sir.
Which one?
Start. E.
No, your option given. I'm telling, if you look
Sorry.
at this guideline, more likely this will be the best answer.
Yes, sir. Yes. Yeah.
You see, it is incidentally matched actually, this highlighted. I didn't highlight for this question. It is incidentally matched. Just to show you that 140 by 90, our blood pressure range is in this value. So a little high up. Patient does not have any other comorbidities, any other problem. Suppose to start the treatment, if the blood pressure is 180 over 100, then consider starting hypertensive. Look at this sentence. If more than 100 over 180 over 110. Only in this situation, consider also meaning you may not start. Just consider to give the medicine. Though our practice is little different, it means we need to go for again ambulatory blood pressure monitoring, because the record of the blood pressure is very important for diagnosis of hypertension. Situation actually modifies it. For that, repetition is important for the measurement of blood pressure. Anyway, the best answer will be more likely B, right? Arrange ambulatory blood pressure monitoring. If it is not there, then you have to choose another option. But more likely, drug treatment will not be the best priority here because blood pressure is just high up. Even advice on lifestyle changes and repeat in 1 year may be important answer here. Because patient does not have family history of hypertension, BMI is 24, and does not smoke. To make it materialized, that means for this advised lifestyle, actually, there are some other issues to investigate the patient. Is there any target organ damage? If you go one step further, if you investigate and check the target organ damage, the initial target organ damage definitely will be the ECG, if any impact on the heart there or not, with urine test to the kidney. Okay, minimum these two things. So nothing is happened, nothing is wrong other than only hypertension value 144/82. I hope that advice on lifestyle will be very important answer as a part of the management. But for further evaluation, if pressure is high up, we have to check it ambulatory blood pressure monitoring or not. Now, look at in your the STEM also. Is it written in the ambulatory or home measurement, Dr. Ashraf? 142, 92, 50, 88. Is it in the home or is it in the clinic? I told you the clinic.
Clinics.
Clinic, confident?
Yes, sir.
Because it is written as that has been seen by 2 colleagues, not by the patient self. So now, look at the answer. Clear now?
Yes, sir.
These make difference in your exam. Somebody will tell, okay, I advise my patient lifestyle and come back. This will be the answer. No. We need to be rational to choose the answer. As already I described in this hypertension, very important topic in our day-to-day life practice. I hope that all of you understood it now. For each and every question, you need to read the question in this way, not directly look at the options. For your preparation, I'm telling. I'm not telling that for your exam day what you will do. This is different, a little different topic. The initial preparation. So thanking you. And the next question, may I request someone to read other than Dr. Ashraf? Dr. Rafia, can you read it? You found second one here, yes.
A 67-year-old male present with dyspepsia.
Your audio is closed, Dr. Rafia. Can you check? Can you repeat?
Sir, can you hear me?
Yes, I can hear.
A 67-year-old male presents with dyspepsia, which started about 2 months ago. He thinks he's lost some weight. On examination, he looks a little pale and has some angular stomatitis. What is the most appropriate management strategy?
Thank you. So to give the answer, actually, we need to consider some keywords, key messages. So who can say some key messages here? Please share with us. If you cannot identify key message, you cannot give correct answer. Can you try, Dr. Rafia? No problem. Key messages.
Weight loss.
Okay, then any more?
Pale.
Pale means anemic.
Anemic. Yes,
okay.
Sir. And angular stomatitis.
So presence of angular stomatitis, what the message you are getting?
Deficiency.
Try to learn today as you are attending the session. You will be the most lucky person today. You will actually not get this guidance everywhere, every time, and is in every session. A patient sometimes told us the diagnosis by the history. Can we say that patient have GI disease?
Yes, sir.
GI disease. Dyspepsia, it is upper GI or lower GI problem?
Upper GI, sir.
Upper GI problem. Does patient have anemia? Yes.
Yes, sir.
Does patient have any clue of cause of anemia?
Mm.
Who can say? Dr. Ashraf or other colleague, anyone? In the history only here or examination also they are right. History and examination both. Any clue of cause of anemia? Yeah, new colleague, Dr.
Yes.
Huaida, possibly. Please.
Yeah, hello.
Hi. Any
Yeah,
clue of anemia?
Anger This means that iron deficiency anemia.
Fantastic, fantastic. Thank you, doctor. So these are the messages we need to collect from the questions. If you say that, okay, 67 year may be a keyword, yes, because iron deficiency in the elderly patient indicate very dangerous disease. So if I like to say you some, Dr. Huaida, please, can you be connected? If you need to say some alarm signs from this patient, what could be the alarm signs or alarm features?
Loss of weight,
Right?
his age and loss of weight and his anemia.
Anemia, right? Definitely. Very good. So if it is so, what will be now your most appropriate strategy? So for your easy purpose, we are trying to show you in our sense, angular stomatitis is also key feature actually to have an idea of etiology, not alarm features, etiology. So these will be the key features here. Now, what you like to do? Your doctor in front of your patient. Please answer now. Dr. Huaida, Dr. Rafia, or anyone.
Progress.
Huaida, what you like to do now for this patient?
Yeah.
Remember,
This is
manage doesn't mean medication. Manage means overall evaluation, reassurance, investigation altogether.
investigation, of course, need to be
So what do you
investigated.
like? What investigation you will offer to the patient?
Yeah, he must go. We must go in the side of the
Endoscopy?
endoscopy. Yes,
Upper G endoscopy?
upper GI
Or will you
endoscopy.
will you go for the H. pylori test?
No,
No?
I didn't say this patient is not going this.
Other colleagues are
pylori.
telling nothing, only listening. Please, can anyone say? You are
So
dealing such
maybe we're
patient.
going.
Quickly, other colleague, please try to share. Only listening. You are
I'm go-
busy otherwise.
I'm going in direction of the CA maybe.
Carcinoma. To exclude carcinoma. Let us see. May not be carcinoma. Okay. So just for learning purpose, I'm showing you these are some alarm features, right? It will be useful for you. Mnemonic, we actually customize for your better understanding. Alarms given in the book, we added this thing 55. Oh, this is the Barrett's esophagus. Age 55. So we have age 67. All are alarm features. Red flag, rather to say. Red flag means we need to explore the disease more. These are the red flags for GI diseases. You must remember it. Keeping this in mind, now what will be your decision? So I'm showing all the steps. Choose now one, please. Please choose one. There are 5 options.
For urgent gastroscopy.
Urgent gastroscopy. Oh, yes. So there is some diplomatic word also. Urgent. Not the routine, right? Because you need to refer. So urgent means within how many days?
2 days.
2 days. No,
Or
doctor.
the same day?
2 weeks.
2
Usually
weeks.
2 weeks. So urgent actually sometimes confuses us. Urgent means as a GP 2 weeks. But within 2 weeks, it doesn't mean after 2 days we cannot do. 2 weeks is the maximum time. That means if you search for appointment, the specialist will give you the appointment within 2 weeks. It may be tomorrow also. No problem. Maximum 2 weeks. So you are thinking it will be the answer. Okay, let's see. As other colleagues are not talking. So this is the answer. Refer for urgent gastroscopy. These are the example of your AKT question. Okay, fine. Now we are jumping to the next. These are the description you will learn by yourself. So we are not here to talk. So these are the text-based question we have shown to you for examples. Now come to the clinical pictures. This is the pictorials, one by one, a little sample. Dr. Huwaida, can you read it, please? Exactly this question you are facing, a little modification for your better learning process. We are not showing you here the options. Now try to read, please, Dr. Huwaida.
Yeah. A young female patient presented with each rash shown here, which
Yeah.
was a few hours duration. After tending her garden, she had a similar mild rash on the arm a few weeks back. What is the most likely diagnosis?
What is the message you are getting from there, Dr. Huwaida?
This
One
acute,
message could be that patient have acute problem, patient might have
yeah,
allergic problem.
it is an acute allergic problem.
Allergic problem. And allergic to which material? Possibly.
Grasses maybe from
Maybe
the garden.
grasses or maybe dust or maybe
Yeah.
some manure. That means fertilizer also. If somebody use in
Yeah.
the garden, right?
Yes.
So if it is said as a garden, if you walk around in the garden or work for taking care of the plants there, so usually people use the hands. Hands will be in touch with leaves and others also, right?
Yes.
I don't know, Dr. Huwaida, possibly you are not from our own culture, own country. Some colleagues might be there. Somebody have the experience in the childhood. When we are moving here and there are some leaves in, if it is in touch, it will be intensely itching. Do you have this experience? I don't know. And sometimes the children are actually moving and behind another children to give the touch of the leaf so that they will have the itching. They are playing in this way also. Maybe this is the scenario similar. So most likely diagnosis, what will be? If you are asked to create some options of the question, what option you will create one by one, you can tell.
It's allergy, of course.
And what will be the likely diagnosis in a medical word?
It can be contact dermatitis.
Contact dermatitis. Very good answer. Very good answer. Can anybody else say a little advanced? Contact dermatitis. I hope you will be correct. So these are the keywords. These are the keywords. Previous exposure, reaction, again reaction. That means this is allergic. Frequent, recurring features are the allergic features. Dr. Rafia, what will you say?
Yes.
Will you agree with the contact or is there any other?
Sir, contact dermatitis.
Contact dermatitis. What are the types of contact dermatitis? Can anyone say? Dr. Saeed. Allergic contact dermatitis. Another? Irritant contact dermatitis. Irritant contact and allergic contact dermatitis. Okay. So actually, it could be difficult to say if anybody knows about what is irritant, what is contact. But contact, there is no doubt. Now look at the options. What will be the best answer? So you are fighting with irritant contact dermatitis, allergic contact dermatitis. Now try to give the best answer by your sense.
Allergic contact dermatitis, sir.
Why you are telling? Your answer is correct, but why you are telling?
Itchy rash.
See, it could be irritant also, itchy rash. Actually, it is hard to decide, but let me try. Some touch of the garden indicating these rashes are there. You see? Linear. Okay. But there
Yes,
are
sir.
some a little bigger area in
Yes, sir.
allergic contact dermatitis, surrounding other areas also involved. Those area actually not in touch, not in contact. Clear now?
Yes, sir.
So there are many examples. If somebody having the piercing of the ear, right? In many countries of the world, ear piercing by in the what is that? Lobule of the ear. But the face is swollen. Or in the neck, skin is swollen or itching there. It is allergic contact dermatitis. Okay. Many
Yes,
of
sir.
you have this experience. Cosmetics, somebody using the cosmetics in the skin, in the face, but reaction happen in the neck as well, additional. It is allergic contact dermatitis. Clear? Thanking you. So this is that hysteric leaves. I think, I don't know, Dr. Ashraf, Dr. Rafi, they're having the experience. Other colleague also in your country, this is that leaves. There is some local name. Huh? If
Yes,
you
sir.
keep touching, it will create the intense itching. This leaf. It
Yes,
is
sir.
called ivy, poison ivy. Poison ivy. Okay. So anyway, we are enjoying our history also during our. So this is one picture, clinical picture I have shown you. I will not show you further. The second one, the fundoscopy. Okay. Who will be interested to read it? Other than Dr. Huwaida and other colleague, anyone? Otherwise, Dr. Rafia can read it for us again.
Okay, sir. A 32 years old female is referred with a 6 months history of headache. She is taking medication for acne and contraception. Examination reveals this fundal appearance. A BMI of 33.3 kg per meter square, a pulse of 75 beats per minute regular, a blood pressure of 120/74 millimeter of mercury, and temperature of 36.7 degrees Celsius. Fundoscopy shown.
Shown as
Don't know.
the picture already given. This is the fundoscopy picture.
Yes, sir.
Fundoscopy shown means you are looking the picture. Okay, then question.
Which of the following drugs may be responsible for this appearance?
That means you will be given some name of some drugs.
Drugs. Yes,
A,
sir.
B, C, D, E. So initially think by yourself which drug can cause such appearance. But we need to know what is such appearance, what wrong there. Okay.
Yes, sir.
This is the basic questions. But one technique also during reading the question in your reading time as well as in the exam time also to save your time. What will be the strategy? Suppose today for our class purpose, Dr. Rafia nicely explained or narrated the question. But when you read by alone, how will you read, Dr. Rafia? Suppose you are not reading for other purpose, you are reading for yourself. How will you read?
32-year-old female.
Why old you will read? You will read 32 female, 6-month headache, right?
Yes, sir. Yes, sir. Yes, sir.
32 female, 6-month headache, medication,
Acne and
acne, contraception, the BMI 33, right? Examination
Yes,
reveals
sir.
why you need to read it. BMI 33.3, not the unit also. Pulse 75, regular, blood pressure 120/70, temperature 36.7. Fundoscopy picture there. Now the question. This is the way of reading by alone if you are alone, but not for today's purpose, right? Everybody, you have to make it habit. Otherwise, you cannot cover within 1 minute your decision making. That tricks actually our intention today to teach you if you don't know, but don't mind if you know from before. So now drug, who can say? That means some drugs concerned for the treatment of acne and for contraception. So which drug could it be of this appearance? First of all, what is the appearance in the fundus? Please, anyone? This is not normal fundus. Dr. Rafia, anyone? If anyone say that I never have seen such picture, I like to say very sorry for you. You must see this fundoscopy is very common topic in the AKT as well as in your OSCE exam. So this is one of the abnormal appearance. You need to read the fundoscopy. If you feel interested, you can see our YouTube channel. If you don't find, you can send request to us. We have some PDF also of this fundoscopy, but PDF is not enough. You need to attend the discussion class. There is a common master class available in the YouTube. Anyway, so this diagnosis is, Dr. Rafia, can you say? Or on behalf of you, I can say.
Sir, please.
Please. Okay. Yeah, this is, you see, this optic disc margin is blurred. Okay.
Yes, sir.
In normal fundoscopy, optic disc margin will be clean cut, sharp. So this blurred margin is papilledema. Okay.
Papilledema.
There are
Yes, sir.
different type of papilledema. Just to let you know, as the other part of the retina is normal. You see, this is normal retina. Only the optic disc margin is blurred. So this is papilledema. More likely a patient of 32-year BMI 33.3. That is, look at some highlight again, the keywords. Sorry, I did not mark it BMI here. I need to mark BMI for your purpose. It is also keyword will be here. Okay. This keyword also will be there. So including this thing, patient was getting acne treatment. So Dr. Afia, minimum, can you say some treatment of acne, name of some medicine?
Isotretinoin. But here,
Maybe difficult. If you don't go through the topic, answer will be not easy for you. Anyway, let's move now. We have very less time to discuss. So patient is on contraception, patient is on acne treatment. From this list, which drug can cause? This is your exact question, exam question. So now try your best to give the answer.
topical retinoic
This is
acid.
the papilledema and the patient having the headache. It is the diagnosis of idiopathic intracranial hypertension.
Hypertension.
Or another word, benign intracranial hypertension. So which drug is responsible for benign intracranial hypertension? Not only the fundoscopy, really, it is a whole picture of a patient. If you don't know, look at the answer. Combined oral contraceptive. Okay?
Yes, sir.
Combined oral contraceptive. So this is the way of learning. Eh? This is the tricks of learning. Your question. So now come to other. Pictorial is X-ray. Dr. Saida having anything to say, Dr. Saida?
Nothing.
Nothing? Okay. Okay. So come to the X-ray now. X-ray example. Dr. Saida, now can you say what is your diagnosis? Just touching all the topics of AKT exam today, a little, not detail. I hope it will be definitely useful. Those who are attending sincerely, seriously in the session. So for that, I'm always exciting you rather to say, encouraging you to take part in the discussion. Is it abnormal, Dr. Saida?
Yes, sir.
Abnormal. Why you are telling this is abnormal? Because there are white shadow in the right upper lung.
Yes.
Okay. So if it is a white shadow, what may be the cause of white shadow there? Maybe consolidation, maybe collapse. Okay.
Yes.
Or sometime maybe fibrosis. Or mass lesion, that means the tumor. But my question to you, could it be the white shadow due to pleural effusion also? But in this picture, could it be pleural effusion? More likely or less likely?
Less likely, sir. Because there
All,
is,
yes.
because I cannot see any fluid level.
Yes, no, fluid may be there, doctor. Just asking. Some fluid in the sky, doctor. Cloud is the fluid, for example. But more fluid in the sea, right? In the down by the gravity. There are some exceptional, I better not to discuss assisted pleural effusion. This is separate thing. But in general, it will not be fluid. It will be collapse, consolidation. Okay?
Yes.
Now, what will be the diagnosis? Who can try now? Because you have gone through X-ray in your undergraduate life also. You are advising your X-ray in the chamber also. If you don't know why you are practicing this profession, isn't it? Dr. Rafia, why not you are trying?
Sir, pneumothorax.
Oh, you are thinking that the black areas are abnormal, white is normal.
Mm,
That the both lungs are filled with air in the pleural space. Almost impossible. Who can say? Who can say, please?
maybe consolidation, sir.
Consolidation. You can say consolidation, but why you are telling pneumothorax? Pneumothorax will be in the periphery. There will be lung margin, other thing. And pneumothorax usually will be unilateral. Okay. So this is why. So to read now, how to read the X-ray also again, it is our privilege to offer you, doctor, to read our YouTube. A long discussion is there. The exploring chest X-ray, though we make it inbuilt in our module also, AKT preparation module. You can see individually these X-ray detail, that different shadows and other. Anyway, so there was somebody, you are telling that this is consolidation. Okay. But could it be collapse, Dr. Ashraf? Could it be?
Trachea shifted to the right. So
Whatever you
lung,
tell you maturely, not like very undergraduate type. You say your diagnosis.
the lung carcinoma.
Why you are thinking carcinoma? Which feature? You don't know the history here only by looking at the X-ray. That means you are telling that mass lesion, right? Tumorous lesion, neoplastic lesion.
Yes, sir.
But could it be collapse?
Possible, sir.
What do you think?
Possible, sir.
Possible. What is the logic? Trachea shifted, you are telling.
Yes, sir.
How to say trachea is shifted? Just we check the spinous process here. Trachea usually a little right from the midline, a little, not much. But here, this is the spinous process. From this spinous process, trachea is actually moved towards right more. One. Now we have to decide is any technical problem or not. The patient is rotated or not. If you don't know, please, again, I am referring all of you to look at our discussion in the YouTube. Look at the end of the clavicle, both end, and look at the position of the spine. This clavicular end should be equidistant from the spine in the right side and the left side. Otherwise, your position will be misleading. More likely in the X-ray, this is normal. What do you think, Dr. Ashraf? The clavicular ends are equidistant from the spinous process. So this is a well-positioned X-ray. Then we decide, is the shifting of trachea there or not? So trachea is shifted to the right. Now, Dr. Rafia and other, those who given the answer, consolidation. Do you like to revise your answer? Is it consolidation or collapse? Dr. Saeed also?
Collapse.
Collapse. More likely, this is collapse. Now come to the issue of Dr. Ashraf, that Dr. Ashraf tried to say this is neoplastic disease. Yes, neoplastic disease in general actually does not cause mediastinal shifting at the time of presentation by itself, Dr. Ashraf, especially for you. It is interesting because there is a space, potential space between two lungs in the mediastinum. So enlarging tumor will occupy the empty space first, but patient will come to you before that. This is my personal explanation why the neoplastic lesion does not actually push the trachea initially. But malignancy will push the trachea or mediastinum in different way. Number one is the collapse, shifting, not pushing, rather pulling. Because neoplastic disease compress the airway and the alveoli become collapsed. So in this collapsed situation, trachea will be pulled in, right, Dr. Ashraf?
Yes, sir.
Okay.
Trachea.
Shifting towards the lesion. But if malignant disease, like the white lesion, causes huge pleural effusion in the same side, where will mediastinum go? To the same side or opposite side? Don't you understand my talk? Suppose malignancy is there in the lung, it is producing pleural effusion huge in the right side. So heart will be shifted to the left. That means a malignant lung disease can pull mediastinum, can push mediastinum. Both are true. Clear now, Dr. Saida?
Yes, sir.
If collapse is there, mediastinum will be pulled in the same side. If effusion, mediastinum will be pushed to the opposite side. In this way, malignancy actually causes the displacement of mediastinum. But in general, the neoplastic tissue itself in the presenting time to the doctor does not displace the mediastinum. It causes some another way, collapse or pleural effusion. So in summary, this is collapse. And what is the reason of collapse? We will explore later. So these are some basic tips, doctor. We need to read in the checks X-ray details. You can look at our detailed discussion in the YouTube. Or you may get available in our trial version of the module also, maybe there. So far I can remember. If you don't have the trial version, you can request to us, we'll send. Okay, this is the next abdominal X-ray. Patient having abdominal pain and other symptoms. But look at the X-ray, tell me very gross diagnosis. Please, anyone? Can anyone try? Dr. Saida. You can see some dilated loop of intestine in the central part. Usually central means small intestine. Okay?
Yes, sir.
Though there are some other thing, their liver will be some little visible. There are some kidneys also may be visible, whatever. But the main focus is in the central part. Coils of intestines are there and large. There are some air, extra air in the intestine more and more. So this may be obstruction is there. But
Intestinal obstruction.
to say definitely this is a small intestine or large intestine, what characteristic feature is evident here? If you follow my cursor from this point to this point, this margin to this margin means throughout the wall of the intestine, there is an whitish line, a little curved. That is the mucosal fold. What is the name of these? Valvuli conniventis. Have you heard this name?
Yes, sir.
Valvuli conniventis. So in the central area, valvuli conniventis. So this is an airs are trapped inside. So it is large intestinal or small intestinal obstruction. This is small intestinal obstruction.
Small intestine.
This is only just a little glimpse. I will not detail more. So now the next X-ray, a relatively younger patient. What you are looking there in the skull bone?
Yes, sir.
What? Any new colleague to participate? Dr. Huwaida, you become silent. Why not talking? Sorry, doctor, if you feel tired or any sickness, I'm sorry. Better anyone to join?
The skull bones.
What is the appearance there? Diagnostic of what?
The thalassemia.
What? Thalassemia. Only thalassemia. What feature telling that this is thalassemia? Hair on end appearance. Hair on end appearance.
Yes, sir. Hair on appearance.
So it could be other than thalassemia also. Thalassemia is common for that you are telling. Actually, answer will be chronic hemolytic anemia. Chronic hemolysis, commonly thalassemia. Hair on end appearance. So we are doing a skull X-ray for what other purpose, other disease diagnosis, other than hemolytic anemia? What do you think? We are doing for a skull X-ray for diagnostic purpose, but patient does not have headache. More likely patient does not have headache, but we are making X-ray in the skull. Sometimes we make X-ray of the sinus. We make X-ray for the headache also to see the pituitary fossa. Any pituitary tumor, this big area will be there, empty space. But here we are doing X-ray to exclude the hemolytic anemia. But what other disease? Patient may not have headache. Even then we are in elderly patient, male patient. Pain in the back, but we are making X-ray in the skull. Can anyone tell now? There might be lytic lesion multiple. What is the diagnosis? More likely? Multiple myeloma. Anyway, what are you looking there? Tell me the diagnosis of this X-ray. There are two arrows. One is here in the right side, another arrow in the left side. So right and left both are not same. So there is diagnostic dissimilarity also. I am showing the typical X-ray in your exam, doctor, to make you oriented. Or not only chest X-ray. Chest X-ray is the most important, but the other X-ray with you need to be ready. So any observation? This is the maxillary sinus. So what is the
Maxillary
diagnosis?
sinusitis.
Both are maxillary sinusitis. So what is the difference? You have to why the missing you. What is the difference?
Looks like the left one is the more air.
More air. Okay, this is air. There is also air. Sinus means air. Air
The-
cells. But the diagnostic clue, you see there is an almost a straight line.
Fluid.
It is called air fluid level. Air fluid level, there is a level. But there is no fluid level, but mucosal thickening is there. Right? Now question is acute sinusitis and chronic sinusitis. Which one acute, which one chronic? Or both are acute or both are chronic? This is acute sinusitis, air fluid level, and this is chronic sinusitis.
Mucosal.
Okay. But sinusitis is not only for looking at the maxillary sinus. We have to look at the frontal sinus. We have to look at the ethmoidal sinus here. And we have to look at the through the mouth cavity behind. What is the name of that? I am moving the cursor, actually posterior part. For that patient is to open the mouth during X-ray exposure. Is sphenoidal sinus behind. But commonest area affected in inflammation is the maxillary sinusitis. For that we are looking first there. There may be some other sinusitis. And this is the most important one. And this is sinusitis X-ray, PNS, OSCE to mental view. Okay, clear now? Right. Now in the hand X-ray, patient complaining hand pain. You are suspecting some rheumatologic disease. It is just to challenge you. Can you identify the hand X-ray abnormalities? Can anybody identify? Your clinical clue will help you also. But in the look X-ray, first look at the distal interphalangeal joint, then proximal interphalangeal joint, then metacarpophalangeal joint, and few in the carpometacarpal joint there. This carpometacarpal here. So look at the PIP, DIP, and the MP. In these three, which joints are affected? Is a challenge for your vision, exploring power of your eyes. Dr. Asha.
Thumb finger.
Interphalangeal.
There are two interphalangeal, doctor. PIP, DIP. Proximal interphalangeal. This is distal interphalangeal. So which are affected? Proximal or distal? Look at all the fingers. All the
So
digits.
distal.
Distal affected. But
Mm,
why you are thinking this is affected, distal? Anybody else to say a little different thing? Suppose joints are damaged here. You see this joint. This is the proximal.
yes.
Okay.
Oh,
But
proximal. So
yes, distal normal. This
yes,
space
sir.
is normal. The integrity of the space is here normal. So proximal interphalangeal joint, distal totally unaffected. This is the diagnostic clue of which disease, rheumatologic disease in hand. Distal not affected. DIP not affected. So what will be the diagnosis? Rheumatoid arthritis.
Arthritis.
Rheumatoid
Deformation.
arthritis.
Yes,
If
sir.
deformity, there deformity, but without deformity, if distal joint not involved, 99% you can say this is rheumatoid arthritis. Okay, remember it.
Yes, sir.
The distal interphalangeal joint not affected. This is the golden word for diagnosis. Okay, please. This is rheumatoid arthritis hand. Now come to other. This is not the quiz for you. Just look at osteoarthritis or syndesmophyte in the spondyloarthropathy. This is the differentiating point here. You see, these are the bridging from vertebral margin to margin. Bridging. It is called syndesmophyte. So syndesmophyte diagnostic of what? Please, anyone? Syndesmophyte. These are your AKT questions actually indirectly. These pictures. Syndesmophyte means spondyloarthropathy, means ankylosing spondylitis. Syndesmophyte here. Now in the syndesmophyte, if there is unilateral syndesmophyte, asymmetric syndesmophyte, there are some other diseases other than ankylosing spondylitis, even the psoriasis, Reiter's disease, or enteropathic arthritis. So you need to read spondyloarthropathy in broad heading, two types. One is the primary spondyloarthropathy. This is the ankylosing spondylitis. Another is the other spondyloarthropathy, secondary to other disease, psoriasis and other systemic disease involving this. Okay, so this is one asymmetric syndesmophyte. But in the osteoarthritis, there will be some bony outgrowth. Bony outgrowth. I am not showing you parallelly here, just to let you know the appearance of this will be the common X-ray for your learning. Now here in the patient presented with, for example, accident from the height. So you made X-ray of the hip, including upper part of the thigh. That means the femur. What is your diagnosis? There is a very important clue. If you don't know, let me say. Just look at the left side. Follow my cursor. Is there any smooth line?
Yes, sir.
Smooth line, right? Okay. Sorry, I already have shown you. You know the diagnosis femur neck fracture. Just to know, look at the line. It is called Shenton line. Normally, it will be intact, smooth. But if you look at the right side, this Shenton line is not maintained, right?
Yes, sir.
Is a broken. This is the diagnostic clue of neck femur fracture. Well, you may not see the fracture line here in the neck area. You may identify that shortening, but the great clue is the loss of integrity of the Shenton line. There are some other line also. My suggestion for your AKT preparation, try to learn this common gross feature in the X-ray pelvis, okay, for your future, because these are common X-ray we need to do in our practice. The next one is lateral malleolar fracture. This is the fracture, okay, malleolar fracture. All right. Come to the ECG. ECG usually diagnoses cardiovascular disease, but ECG can diagnose other than cardiovascular disease. Rather to say not vascular, cardiac disease. And very common investigation weapon in our hand. Every doctor should know about ECG. For that, we are showing the ECG. Now, just for learning purpose, we are showing the information as well as one ECG. So who will feel to read? Dr. Huwaida, are you there? Can you read it for us, Dr. Huwaida? Huwaida. Otherwise, Dr. Saida, please, you can read.
Okay. A 43-year-old woman with a history of well-controlled hypertension and diabetes presents to your office complaining of intermittent chest pain for the last 3 months. The last episode was 1 week ago. After climbing 4 flights of stairs at work, the pain was relieved with rest. An ECG in your office is shown below. She is currently asymptomatic. Which of the following is the most appropriate next step?
So option will be shown to you a little later, but try to understand from the history of the patient. Is it cardiac pain? What do you think, Dr. Saida? In the history, in the background?
No, because it is present since last 3 months.
Okay, pain coming and going. So coming and going could not be cardiac pain.
Yes, cardiac pain is it is sharp, intense.
Okay, these are the characteristics: sharp, intense, but this is exertional pain. Okay.
Yes.
You see, the last episode 1 week ago, after climbing 4 flights of the stair.
Maybe, sir.
Maybe, right. Why maybe? Is there any other background?
Because it's the pain was relieved with rest, and
So this
with
is
exertion
ischemic pain, one type of ischemic pain relieved by rest. But any background disease patient might have which influence the heart disease. Who can say? Please, it is very critical for your exam, any exam in the world, doctor. Try to understand, please. ECG question usually presented in such way, not only direct a picture and tell the diagnosis.
Pulmonary hypertension.
Is there pulmonary hypertension you are thinking? Don't look at the ECG first. Look at the history first. Try to understand the history. What is the comorbidities of the patient?
Hypertension and diabetes.
Fantastic. Why you are not addressing this thing? A patient, a young lady, 43, only chest pain. You may ignore. Only. Right?
Yes,
Ladies,
sir.
please don't mind. It may be only functional. Chest pain. Is that
Yes,
it?
sir.
But if the lady
Yes.
having the diabetes, hypertension, dyslipidemia, smoker, is not different thing?
Yes, sir. CVD risk is high here.
High. Invariably, in all diagnostic question, you will get such messages for any disease doctor. Don't ignore it. If you learn today, think that this is a golden time for you. You have learned it today in these questions. So background is always important, even the age and gender also. So with the background, this thing, cardiometabolic risk, the chest pain is ischemic. Now, it could be stable angina, okay? As is coming and going, right? It is stable because it is relieved by rest.
Yes.
Simply. If it is so, you have done one ECG, right? Usually we do it in our chamber. This is the appearance of ECG. Now challenge to you, there are two things. Identification of the ECG feature, then what will be your next management step? So first identify the ECG. Can anyone identify what is wrong there? Dr. Saida.
Sir,
Many,
in
please.
LED 2, is there any T wave inversion in LED 2?
Yes, why you are asking? This is obvious. Yes, obvious. Lead, you see 1, 2, 3, from 3 up to 6. Below B1, V1, 2, these are the long lead for the rhythm to check the rate and rhythm. But the 12 lead is above here up to this. So V3, V4, V5, V6. This is one features of ischemia. T inversion means ischemia. But there are many other causes of the T inversion. It is true. But we need to be confident now for diagnosis. One thing. Or we need to start the medication for this patient by labeling this is ischemic heart disease. This may be another option. Or we can say, don't worry, as you don't have chest pain now, go home, take deep breath. It may be another decision. Okay. This ECG of is shown, you have done today. Today, no pain, but you got some ECG feature. Is the decision making very easy now, Dr. Saida?
Yes, sir.
Yes. Oh, good. Oh, good. So tell your very easy decision. What do you like to
No, it's
decide
not.
now?
I mean,
You're thinking.
since you are giving us options, so I told you it's
I will
easy.
not tell option now. You need to bring your option from your brain, because in the chamber, patient will not tell you option, doctor. Right? So you need to give your option first. You may be wrong. You may be right. That I'm telling today's session is a little extraordinary session for you. What will you do? Will you give the treatment now or any medicine, or will you give
Yes,
further
we will
investigation
start.
plan?
First, we will give her aspirin.
Oh, you are giving the medication for ischemic heart disease.
Yes.
Aspirin and other. You will do lipid profile. You will already patient have diabetes and others. You will continue diabetic medication, hypertension. Okay, Dr. Ashraf, what will you do? Do you like to do any further investigation for this patient?
Sir, cardiac enzymes?
To exclude myocardial infarction.
Yes.
But patient does not have any pain today right now. She is currently asymptomatic.
Reassure.
Or you are thinking, doctor, our female colleague is a functional as a lady?
Echo.
Asymptomatic. So could it be functional? We're in the puzzle now, right? Dr. Ashraf, what do you like to say?
Reassure.
Reassure. Oh my God, reassure. Patient having diabetes, hypertension, chest pain before. ECG also there is some change. And he will say that, don't worry, eh? Dr. Ashraf? And our Arab colleague will tell, Mafi mushkila. Is it?
So we should start the disease management.
Doctor, what will you say now? Any further evaluation needed? Okay, let's try to learn. Okay, don't worry. As you are the learner, you will get the option also there in the exam. So these are the options in the below, please.
Fair.
So which option? A long options are there. So try to choose. A little advanced question of ECG though, I believe, but for our learning session, doctor, I have selected this type of question. But exam question so far will be a little simpler, not this much advanced.
Sir, D, option D, obtain the patient's treadmill stress ECG.
What is your intention? That means to be more confirm about the diagnosis.
Yes.
Okay. It is one of the rational approach. Any other? Any different opinion any doctor can think of?
D.
B. Bangladesh. Reassured the patient, but increase her medication to tie
Not
for the
B. D, I thought.
D. Same. Obtain treadmill. Treadmill stress ECG. Okay. That means exercise ECG you are thinking. But this is another option, treadmill with echocardiogram. This is another option also. Because this is also another option of diagnostic modality for the ischemic chest pain. So think of it, or somebody said that enzyme. Okay, do you see option there? Somebody, Dr. Ashraf said, reassure the patient and return home. No worry. Is a female, 43. Okay. Dr. Ashraf, I'm sorry, I cannot tell in your native language what you will say in the lady. Go home. Don't disturb. Dr. Rafia, don't disturb. Go home.
No, sir.
Not so. Let's see now if nobody having a different opinion. So those who given the answer treadmill stress ECG, I appreciate you because these are very common attitude, a common plan, and many of you have seen the report also. But rarely, very uncommonly, echocardiogram with the stress. That means a stress given, then check the echocardiogram. Why not ECG stress? Because ECG already shown some picture there. You see, our colleagues nicely said, possibly Dr. Saida said, there is some T inversion suggestive of ischemic disease. Now we need to be more confident about the diagnosis by the echocardiogram if there is wall motion abnormality. Have you heard the word? Regional wall motion abnormality in the echocardiogram. It is very suggestive of ischemia. That means muscle is not active more. To see these, the best option will be a stress echocardiogram. And stress ECG, there is a more false positive and false negative rate, especially the female. For that, I have marked there in the red word female, woman. So in the female, it's better to avoid a stress ECG for diagnostic purpose. I think you got the message now. Okay, Dr. Ashraf? Dr. Ashraf?
Yes, sir. Yes, sir.
Don't tell go home, Maafi mushkila. You understand maafi mushkila, Dr. Ashraf? Possibly no. Our very nice Arab colleagues are here. They can explain you. Maafi mushkila. La mushkila. Okay. But don't tell any cardiac patient. La mushkila, maafi mushkila will not be our attitude. If any minimum suspicion of cardiac patient, we need to explore or evaluate further. Because this is the system of life and death. Okay. So you see this angina. Please, Dr. Ashraf.
So the question is for investigations.
Yes, management of investigation. Then you will decide further. Then you will give. But you look at the question. This is the lead-in. Appropriate next step. They will not tell you appropriate next investigation. Because in general sense, a step means investigation, management, medicine, everything. Okay.
Yes.
You will get the option in your exam. It will be easier for you. But today for learning purpose, we are trying to make you more competent for each question preparation. Fine. I don't know how much you are enjoying today's session, and until you are here, I am grateful to you. Now come to the example of lab data question. Lab data. This is the basic format today we are discussing throughout the world in all written exam system. The questions are selected in these headlines. Okay. So now the next, who wants to read it? Dr. Rafia.
Yes, sir. A 32-year-old female present with weight loss and irritability. Thyroid function test reveal pre T4 is 32.9.
High. You just mention the high also, otherwise nobody will understand. Free T4,
Okay.
32.9 high. Then TSH?
Low.
No, mention the value and then say
Oh.
low. TSH?
Less than 0.02. It is low.
Okay.
Free T3 is 11.1. It is high. Then examination reveals a fine tremor, pulse of 95 beats per minute, a smooth goiter with a bruit, and lead lag only without any other eye sign. What is the most likely cause for this thyroid function test result?
So what will be the cause of this result? Who will give the answer here?
Thyrotoxicosis.
Thyrotoxicosis is the cause. Hyperthyroidism, thyrotoxicosis, it is not the cause of this disease. Already your background information is given here. This is the presentation of toxicosis or hyperthyroidism. Clinical features, symptom, investigations means this is thyrotoxicosis. It is not like that somebody showing you a banana, they are asking you what is this? And you are telling this is banana. It is not that. Okay, doctor. This is the philosophy of learning the disease of thyroid. That's the gap I had in my previous life. You will learn today of thyroid disease. You see TSH is low, T3, T4 high. Who will not tell this is hyperthyroidism? But why they have told you without any other signs, other thing, there are many other reasons. Patient having a smooth goiter. There is a bruit. That means the increased vascularity. Tremor is there. This means the features of the hyperthyroidism. Now, cause of the hyperthyroidism. There are many causes. For example, toxic goiter, right? Multinodular, that means the single toxic goiter, nodular goiter. Then multinodular goiter with toxicity. Then Graves' disease, dequervence, it is called subacute thyroiditis. Initial Hashimoto also, initially few days maybe hyperthyroidism, many there. From there, you need to choose the answer. Who can say the answer now? So you already identified these key features. Smooth goiter mean with the bruit.
Fine tremor.
What is the answer now?
Fine tremor.
Dr. Fine tremor will be keyword, no doubt. But the question is cause of the hyperthyroidism. By the fine tremor, you cannot say the cause. By the fine tremor, you can say this is hyperthyroidism. But cause of the hyperthyroidism, you need to address this smooth goiter and the bruit. That is, it is the Graves' disease. It is toxic goiter or multinodular goiter or other. Answer will be? Answer will be?
Toxic goiter.
Toxic goiter, toxic multinodular goiter. Dr. Ashraf, open your eyes by closing your eyes. Okay? Look at by closing your eyes. Smooth goiter. Smooth goiter with bruit. The multinodular goiter is smooth goiter.
No.
No.
Graves.
So smooth goiter means Graves' disease. Graves' disease. Graves' disease. And this is the commonest cause of hyperthyroidism also. So this is the way of learning. So in the thyroid disease, in the hyperthyroidism, doctor, remember, hyperthyroidism is a presentation. It is not the disease. The disease is behind. It is the goitrous disease or non-goitrous disease. It is a drug-induced hyperthyroidism or not. It is a Graves. It is Hashi. It is carcinoma, or carcinoma usually does not have any thyroid dysfunction. Or the toxic multinodular. Clear now, everyone? Dr. Rafia?
Yes, sir.
From today, we will read the thyroid in this way. One is the cause, another is the presentation.
Yes, sir.
And in the book, interestingly, that you will see in the book, even the textbook, features of hyperthyroidism. In the same box, they are written This fine tremor, the fine tremor pulse are the other, including goiter, smooth goiter. So these way of presentation actually, in my sense, not perfect presentation, even in the textbook for learning, because in the box, we are writing or learning both the cause and presentation, not the features of hyperthyroidism. For example, goiter is not a feature of hyperthyroidism. Goiter is the cause of the hyperthyroidism. Clear now?
Yes, sir.
So goiter is not the feature. In the Graves' disease, some patient may have hypothyroidism, doctor. In Graves' disease, some patient may have euthyroidism. So why we are thinking that the Graves is hyperthyroidism? It is not true. Most of the time true, but in real sense, it is not true. Clear? Dr. Saida, Dr. Roida?
Yes, sir.
Okay. That means it is not sawa. Okay. Those who understand, you understood. It is not sawa. It is not same. Okay. Different thing. So you got the answer now. So thyroid bruit and the diffuse goiter very suggestive of Graves' disease. So this is one of that lab database question. So our primary discussion of the topic near the end. One extra thing just to show you ultrasound as a GP we are advising, but we are not looking. Just look at the picture, ultrasound picture, doctor, for your learning purpose. Maybe a bonus picture for you today, and don't leave. You see, this is the kidney, peripheral black area is the cortex, in the central whitish area is the medulla. It is called corticomedullary junction, and the appearance is called corticomedullary differentiation, CMD. Normally it is maintained. You just compare the diagram, semi-diagram right side. If chronic kidney disease, this differentiation is lost. Commonly we get it in chronic kidney disease. It is just simple message for you. And my suggestion to all of you, whenever you advise ultrasound, patient brings to you back, try to open and look at the picture and try to read the description, not only the diagnosis at the bottom. If you do this, what I advise now, you will learn many things from there. And in future, doctor, I hope you will pass within this coming time or later, maybe 1 or 2 years also. Royal College can include this type of common simple ultrasound picture, because this is very common. This is my forecasting, doctor, as I am researching many times for the exam. Okay. So this is one, and this session being over now, and there are many link, doctor, for you in the YouTubes. A lot of things are there. If you want, you can go through there. And already I have told you X-ray ECG. You see, this is the X-ray link. This is the ECG. 4 links are there, and day by day it is being improved and increased. We are enriching this store also. Thank you very much for patient hearing.